Okay. Thank you everybody for coming. Today we're going to talk about a very common problem, lumbar disc herniations. Did anybody hear this talk? Was anybody here for the last lecture for this? Rob? Just Rob. Okay, so it's a little bit of a review, but all the cases are new. So in that sense, it may be worthwhile. So let's start with the case. Illustrative cases are a great way to remember things. So this is a 38-year-old woman with right sciatica, and she had these symptoms for approximately I'd say about 6 weeks, and she tried medications like ibuprofen over the counter. It didn't work, and she has pain that runs down her buttock, thigh, lateral leg, lateral malleolus. So Doug, 38-year-old woman with right sciatica, presents to your office. 3 weeks, runs down her buttock, thigh, lateral malleolus. Worse when she coughs and sneezes. She took Advil around the clock. It's not getting better. What would you do with her? Takes Advil.
I take a thorough history and perform a
She's
physical
very,
exam.
very healthy, 38, no medical problems.
This is the first time she's ever had this?
First episode.
First episode?
She said she coughed and sneezed, and immediately after that had pain down her leg. Not getting better. She limps too.
She limps?
Yeah.
And she's got a normal physical exam?
Yeah, other than,
reflexes.
symmetric reflexes, no significant no motor deficits, some lateral, some dorsum foot numbness, and a positive straight leg raise. Everybody know what a positive straight leg raise is? Yeah. So when she extends her knee like she's going to kick a soccer ball, it gives terrible pain. She can't do it.
And measurables,
Huh?
what's the size of this woman?
She's a very beautiful woman like Candy. Just picture Candy. Beautiful young woman like Candy. So what would you do with her, Doug?
I'd tell her to pursue non-operative modalities. I think she has sciatic nerve irritation. She's probably, but I think...
No MRI. Would you order an MRI in 3 weeks?
First, yeah, probably not.
Okay. So what medicines would you give her?
Give her an anti-inflammatory. Might give her some pain medicine.
Okay, so opiates and non-steroidals.
Yeah.
So that's very reasonable. And you know what's interesting is when you look at the literature for what actually helps long-term, nothing actually helps. But at the same time, you have this human being in your office and they need help somehow. So you got to give them something. So I guess the options are opiates, muscle relaxers, non-steroidal inflammatory drugs, steroidal inflammatory drugs like Medrol dose pack, and then like antidepressant type medications for help with nerve pain. You use like Lyrica, Neurontin.
Use Elavil,
Elavil.
but usually not on the first visit.
Low dose Elavil, like amitriptyline,
10
nortriptyline.
milligrams.
10 milligrams at night.
Use that more for cervical spine and people that have
Diabetic neuropathies.
diabetic neuropathy or nerve injury from a fracture or something like that, like a rehabilitation problem.
Okay, they help. So here's the MRI. Dr. Dinkar, what do you think of this MRI scan here? So it looks like there's a L4, L5 disc. Here the vertebral bodies, the squares, and the discs are in between. And you see here's a spinal canal, and there's nothing really within the spinal canal at all, except for here at L4, L5. You see this disc is bulging backwards into the spinal canal. And here's another. Uh-oh. Oh man, hold on. This is not good. Sorry. Okay, good. So here's here's another view of same patient. You can see she's got a little bit of a bulge there at 5'1", but more so at 4'5". And here's a cut off the midline, still sagittal. Here's the pedicle, and here's the foramen. So the foramen is what we use for Latin for the hole where the nerve runs out. And you can see this is the nerve root, and here's the foramen. You see at this level, the foramen is somewhat smaller, probably due to this disc herniation. But also what else can cause it is the facet. If the facet is hypertrophic posteriorly, that can compress into the foramen as well. So here's L5-S1. Here's the S1 nerve root. Here's the L5-S1 disc. And this is an axial cut, so cut straight across. And you see how the disc goes straight across and the spinal canal is here, and nothing is compressing the nerve roots. Here's the ligamentum flavum. Who knows what the ligamentum flavum is? The yellow ligament, which connects the two lamina. Here's the facet where the two vertebral bodies come together. And here's L4, L5. And remember, here's the same disc herniation on the right, compressing the nerve root. Here's the right L5 nerve root as it exits as it's traversing the disc space. And here it is on the left. So you see the right one's compressed and the left one's not. And you see where it gets compressed against the facet and the ligamentum flavum. So if the facet is big and the ligamentum flavum is big, that decreases the area for the nerve root there as well. And it's compressing the disc. So here's what the L3, L4 disc looks like, totally normal. So see how the disc herniation is compressing the L5 nerve root? So let's say she doesn't get better like at 6 to 8 weeks. Would you send her to me as a spine surgeon, or you send it you send it to Benalcazar usually? But when do you wait? Like 2 months, 3 months, 4?
It depends on patient demand. It's really a double-edged sword, because a lot of times you have people that are complaining of pain and they want treatment and they want to think that you're doing something. When you look at outcome studies, the outcome studies at a year aren't too much different no matter what you do. But if I think that they want surgery, if they want surgery, then I send them to a surgeon. If they don't want surgery, then I try to work with them a little bit.
Yeah, outcome studies are kind of funny though, because the outcome's the same in a year. Let's say the outcome in 100 years, which is a really long-term outcome, it's always the same because we're dead in the ground, dirt, right? So you gotta you have to understand what outcomes mean, long-term outcomes. So let's say if you tell like you have this terrible pain, in a year you'll be all right, but between those 365 days are not good days. I mean, they're miserable, right? So I guess the question is like, what is it going to be like week 1, week 2, week 3, week 4, week 5?
You mean after you have surgery, or
if you don't have surgery? If you don't have surgery. If you have surgery, this pain goes away immediately.
Absolutely.
It does. The sciatica pain does. The back hurts for a couple weeks. It does.
Right.
So the question is, how long do you want to suffer with this? I think.
Right. So if this is the first episode that they're having, I'll try to nurse them through it. And if it's non-progressive, if it gets better with minor activity modification, I tell them what things make it worse. For example, driving makes it worse, smoking makes it worse, increasing your abdominal pressure, Valsalva, a guitar, things like that make it worse. Things that make it better, you can supplement. But sometimes with an MRI, you do have nerve. If you can't get the nerve irritation resolved, that's not going to get better.
So let's ask Tara. Tara, if you had this patient, a disc herniation, how would you treat it? Physical therapy.
I would work on the way that they're sleeping.
What would you tell them how to sleep?
I would have them lay on their side or lay on their stomach for a little while. But if they were on their side, I would want them with their legs towards the back in extension.
Like in a fetal position?
No.
Or the other way?
Extension. Give them some exercises that could help alleviate the tension in the nerve.
Okay. Do you do McKinsey exercises? And what do they do? How do you centralize the pain?
By putting them in extension.
Sarah can help too.
It's progressive extension. For
Extension.
most people, right? They can start kind of just mildly propped, and then they can some people can't tolerate complete progression of that, but they can always start kind of mildly propped up and going from there.
Mm-hmm. Okay. So so here's so this patient went to surgery, and this is the surgical microscope that magnifies everything about up to like 12 times, and it makes it very easy to see things well. And let me show you the surgery itself. So this patient did very well from her first surgery. So, give me a second.
Spiro,
Yeah.
was surgery done from the time of presentation? How many weeks out?
Usually, I give everybody about 2 or 3 weeks at least from the initial presentation, and then my rule of thumb with patients is I ask them, are you absolutely miserable? Do you feel that you cannot live with this? If they say yes, then I say, well, you should probably have the surgery. If I say, are you getting better? Do you think you could give this more time? Because there's a good chance it may go away. If they say yes to that, then I just give them as much time as they want. And then I say, when you're ready for surgery, just call me and I'll be glad to post it. But I would at least give it a week or two, because usually, unless they can't walk. If they can't walk, you need to do it, despite pain medication.
Any type of epidural intervention or?
No, I give that as an option. So I tell everybody, what I tell everyone is there are many options for these spine conditions. You can have epidural steroid injections, you can have acupuncture, you can have physical therapy, you can have chiropractic treatment, you can have medications, you can have traction, you can have surgery, and I write them all down and say, you can do whatever you want, and let them decide. And so that's the gamut of treatments.
At what point would you order any type of nerve conduction study?
I almost never order nerve conduction studies unless I feel that there's some kind of neurological condition that I'm missing, like Guillain-Barré syndrome or some type of amyotrophic lateral sclerosis or something like that. So just so you understand how the surgery is, this is the lamina, and this is a high-speed burr. This is a 3 millimeter high-speed burr, and you thin the lamina to get to the fecal sac. And this is done through about a 1-inch incision, and you're looking through the microscope, so everything's magnified. And this here is the ligamentum flavum, or the yellow ligament. Remember we talked about the ligamentum flavum, it's right against the nerve roots. And this here is the fecal sac, and you can see, if you look carefully at the fecal sac, it's pulsating. So every time the heart beats, the epidural vessels expand, and that actually makes the fecal sac pulsate. See that? And that's a Kerrison punch, and that slowly removes the ligamentum flavum away from the nerve roots. So you're always working away from the nerve roots. And that's a suction tip that sucks the blood out. So this is how you expose the nerve roots, and this is the nerve roots. And the fecal sac, which covers the nerve roots, the fecal sac, as you know, is full of water, so it's kind of like a balloon full of water. And inside of them are the nerve roots, and the nerve roots themselves look like angel hair pasta, like really tiny little spaghettis. So let's just, so then take out the disc material. I'll show you we have this great microscope that really gives beautiful pictures. So the disc is deep to the nerve root, see that? And now this is a little grabbing instrument, and it's going into the disc space and it's pulling away disc fragments. So this is basically what a discectomy is. The nerve roots are gently moved medially, and then exposing, see the disc? And the little disc fragments are taken out. And you can see what it looks like. It looks a little bit like crab meat, sort of. This white material. So then,
That nucleus pulposus, or a combination?
it's sort of a combination, and I'll get to that in a second. I'm going to answer your question well in a second, because that's always a question, like what is it? What's the nucleus pulposus? What's the annulus fibrosus? So here's some more. See the disc material right there, and that's connected. The disc material is connected to the annulus. So it's never like like one simple free fragment. Usually it's like sort of like a scar ball, unless you do the surgery the second it presents. Because if you wait a little bit, what happens is it scars down a little bit, and that makes the surgery a little more difficult. But you have to give people time, because a lot of people just get better. So at the end, near the end of the surgery, after I've taken a good amount, I stick this. Let me show you. It's a pediatric suction tube. So it's like a very small, I'd say 4 millimeter diameter tube, and I stick it into the disc space itself, and then I flush it with antibiotic solution, and I do it for two reasons. One is it irrigates the disc space itself with antibiotics. The disc space is avascular, doesn't have a blood supply, so it could get infected. And also it removes free disc fragments. So if you look carefully here at the disc space, it's being flushed, and it can remove disc fragments too. So within the disc space itself, there could be a loose disc fragment, and if the disc fragment is loose, when the patient does more activity, cough, sneeze, whatever, another piece can come out. So you see, I just flushed it, and see what it brought out. This very large disc fragment, which is probably more annulus than nucleus fibrosus. And then you can see how many disc fragments it removed. And if I always feel like if I hadn't done this would have come out 2 months post-op. And it also irrigates the disc space. Okay. So any questions about the surgery itself? And these cases are usually done as an outpatient. It takes an hour, they go home the same day, and the sciatica usually goes immediately. And the back hurts for several weeks, and usually I tell people 4 to 6 weeks, take it easy. I'm not very strict about restrictions. So then the pain came back 2 years later, the same exact pain. So does anybody have any, what could that be? Same patient. She did great for 2 years. She says it's back.
And you said she was good looking?
that woman's not good looking?
Okay.
You're weird.
So
She's not as good looking as Cammie, but she's good looking.
Sometimes you can get a recurrent disc herniation. Sometimes you can get a disc herniation at a different level. And then sometimes you can have something completely different, like you can have facet arthritis, or you can have surgical changes depending on what type of surgery was done.
Right, so maybe the bones are sliding back and forth. It could be instability, it could be another level. The spine's made up of many levels, so you can see the spine's 1, 2, 3, 4, 5, 6, all these levels, any of them can go bad. But chances are it's the same level. So here it is 2 years later, and here's L4, L5. You remember what it looked like before. Looks even worse now, doesn't it? This is really big disc herniation, and it's gone down a little bit inferiorly towards the pedicle of L5. And here's another view. And this is with dye. And the way dye works is that you can be fooled with MRI scans, because what is actually scar could look like disc unless you insert dye. So if you insert dye, it goes to the very vascular areas, and scar lights up. Scar is usually kind of vascular. It also lights up tumors and infections, but in the case of recurrent disc herniations, it differentiates scar versus recurrent disc herniation. So here, when you administer the dye, the disc fragment still looks exactly the same, which tells you it's not scar of the nerve root, but rather disc. Oh, shoot.
And is this really the same person?
Yeah. So
You removed this. How come the intervertebral space is about the same as it was before?
it does, doesn't it?
Yeah.
I didn't take a
Good.
lot, but you did see that big piece. I didn't take a lot, but
Yeah.
it used now 40 years ago when they started doing discs, they used to take out all of the disc and actually measure it and make sure they got the whole thing out, and people would have horrible back pain afterwards. So now the rule of thumb in spine surgery, you just take out what's loose and leave the remaining disc in there so you don't get back pain. But you can get a recurrent disc herniation, so that's the rub. It's a two sides of the coin. One is you want to take out a lot of disc material so you don't get a recurrence, but the other side is you want to leave disc material so you sort of have a normal spine so your back doesn't hurt. So here's the axial cut, same area. Now you can see there's a hole here where the previous disc surgery was, and that actually gives the fecal sac some more room, but there's this really big piece here. And the other problem in these recurrences is everything is tethered. Everything is tethered from scar, so they're more likely to have pain because the nerve root's scarred and it can't move. I'm sorry, guys. I gotta give it a glass of water. So most spines are kyphotic. So this is a raccoon. Most lumbar spines are kyphotic. You see that? Very few animals have lordotic spines. So you see, if we evolved, I'm not sure if you guys are evolutionists or what's the other one? Intelligent design. But mostly kyphotic, and then we stand up, and the lordosis comes mostly from the lower back, and it frees up our hands so we can carry objects or cell phones. So most of the lordosis is here in the lower back, in the lumbar spine, and that lordosis is mostly at L5S1 and L4-L5. So half of lumbar lordosis is at L5S1, the other half probably is L4-L5, and this area is mostly straight. So I personally think because of this excessive lordosis that we have as human beings, it predisposes us to disc herniations at L4-L5, L5S1, and arthritic abnormalities.
Design defect.
Right.
Straighten that up a little bit. Bit of that better. It's like a Brazilian butt lift or something.
Okay, we're back. Sorry, everybody. But this is a child who probably died of a car accident, and I forgot how I got this slide. I think I got that when I was a medical student at Hopkins. And the inner part's totally hydrophilic or water, and the outer part's collagen. And you can see what a normal disc looks like. This is what all disc herniations look like. There's not as much water in it, and it's the outer part's irregular, and you can tear through here. This is the vascular supply of a greyhound, but it's very similar to children. You see how the end plate has blood supply, and it's innervated through osmosis. And this is a disc, and it shows you this is staining for pain fibers, and you can see there's no pain fibers in the middle. All the pain fibers are on the exterior. Just as I thought Adam would be here and we talk about this, but the disc could be degenerated, or it could be prolapsed, not past the posterior longitudinal ligament, or it could be into the spinal canal, or it can be extruded into the spinal canal. So these are just words that they use. So this goes to show you, here's a normal disc, and here's the desiccated disc. And these, when people go to surgery, always look like the one on the right. I've never done a surgery with the one on the left where there's water, because they don't herniate. And the other reason why disc herniations are painful is that the nerve root's tethered. So in the spinal canal, the nerve root's connected to the conus at the top, and it's also connected into the foramen where it runs out. And there's also the rootlets are connected to the vertebral bodies. And because it's tethered, something's hitting it. If you can imagine, if you put a knife here and start cutting, you could cut the rope, but if the rope was free, you couldn't cut it. So when something is tethered, it's more sensitive to pressure. So that's kind of like another thought. So let's do another case. A 19-year-old with right low back pain, right low extremity pain. She said the left side hurt in the past, but it's self-resolved. So what are your, who wants to take? Eric, what are the findings here on the x-rays?
Slight decreased disc height at L4-5.
So you see how the disc height's a little bit small there, everybody? So the end plate looks a little bit dark there. See that compared to the rest of the end plates at 4-5? Okay, so Eric's focusing in on 4-5. And do you see any abnormal motion on flexion extension?
Yes, it's retrothesis with extension. L4-5.
Okay, and maybe a tiny bit of abnormal motion here in retrolisthesis at 4-5. The other thing is that this patient does not have much motion on flexion extension. Now that could be she's just stiff. It also could be pain. So This is a gymnast at GW. This is my first job at GW. I was covering the game as the sports guy was on vacation, so I had to cover all the sports at GW. And I asked her to do a back bend, so I can take a picture of it. You can see how much lordosis is possible in the lumbar spine. It's unbelievable. And I got this from the internet. Like this woman almost does like a 180 degrees in her lumbar spine, and the neck is very mobile too. The chest is not so mobile. All right, it just shows you the mobility of the spine. So we'll go back to our case. So what do you think of the MRI, Eric?
Desiccation at L34 and L45.
So this is the desiccation that Dave has been so worried about the whole conference. Is dehydrated, and at 4.5 it's flat like we thought on the X-ray, and then there's a herniation at 4.5 as well. It's somewhat at 3.4. Disc is bulging at 3.4, right? Yep. 5.1's normal, 2.3's normal, 1.2's normal. And this girl's 19. And it's very young to have all these degenerative changes. So it's kind of weird is sometimes like there's all sorts of people that take care of spine. A lot of primary care physicians and non-spine surgeons say, you're 19 years old, you can't have spine surgery. Well, tell it to this girl. I mean, she's got 2 degenerative discs, she's got pressure on her nerves, she's got sciatica. So what do you see on the axial cuts, Eric?
L45, she's got a central right disc herniation on the top right, and you're at your
Just 2 views of it. 5.1's open and normal, right?
Yeah.
And 3.4 doesn't look too bad, right? Okay, so any questions about this case? 19 years old. I mean, she's too young for surgery. What is it? So I don't think there's such a thing as too young for surgery. If someone's got horrible sciatica pain and have findings and they don't get better after like months of medications, if it were my daughters, the girl needs surgery. And what are you going to do? You can't have her suffer her whole life. So, so she had a right-sided. I did a hemilaminectomy decompression, and then I decompressed the opposite side by undermining the lamina. So opened her spinal canal centrally at 4.5 because she said she's had left lower extremity pain in the past. I did a minimal 4.5 discectomy, and what was interesting is the disc was actually hard. This thing was not soft, it was hard. So that tells you it's been there for a long time. So instead of like taking out disc and doing like a major construction job removing this nearly calcified disc, I just opened it up posteriorly. Does that make sense to you guys? Like,
What do you make of the marrow edema at L4, L5?
yeah, you see that?
Yeah.
That so you can, that tells you that this process has been going on for a long time. The girl's only 19, so it's probably been going on for 5 years, I would say. Because kids don't deteriorate their spines until they're like 14, 15. You never see a 10-year-old with a degenerative disc, ever.
So it looks like she's shifting her stress from her disc right to her vertebral body. She's almost like bypassing the disc.
Yeah, but see how flat the disc is?
Yeah.
So at some point after the disc gets so flat, the forces go to the vertebral body, and she's got a very deteriorated disc at 19.
So what do you think her long-term outcome is going to be from a simple discectomy? Do you think she's going to be, this is going to resolve her symptoms completely?
Sciatica's gone. That's true. But the question is what will happen to this girl in her life.
Right.
As an adult, she'll get back pain, probably. Whether that back pain will manifest in a disabling back pain or just an occasional back pain or a chronic back pain or a mild back pain, nobody knows.
So would you approach her differently if she's got a hard calcified disc with changes on both sides of the disc versus someone that has a soft, pliable disc?
Yeah,
I would be a lot more aggressive here.
in the hard disc?
Yeah.
No, I would leave
back to the back wall of the vertebral body.
I don't know. Let me show you something to give you so you can understand. This is that previous case of the recurrence. You see how this patient has had surgery. You see how the thecal sac has more room because it's had surgery.
Right.
So just by decompressing posteriorly, it gives the roots more room, and they should be fine. Now this thing can definitely take it out, but hers was not that big.
This is the one that recurred.
This is the one that recurred. But
Okay.
just to show you, by decompressing posteriorly,
Right.
you give the nerves more room, and people are fine. The nerves don't have pains. So just take away this ligamentum flavum.
The spinal bifida neurosurgery.
Sort of, yeah. So just by taking the ligamentum flavum and cutting the facet a little bit, it gives the roots 3 millimeters or so, and that's enough. That's all they need. So for me to take this whole thing out, it's calcified and hard like a rock, I'd have to get a reverse curette and a mallet and chisel that, and I'm doing that next to these very vital structures. So this doesn't make sense. So I took away some that was loose, but most of it I left intact. Okay, so any questions about it? We have one more case. We'll finish up in 5 minutes. Unfortunately, we had problems with the computer today. This is a 60-year-old man with right sciatica and Charcot-Marie tooth disease and weakness. So he's right sciatica. Does everybody know what Charcot-Marie tooth is? It's a hereditary neurological disorder where something happens to the myelin sheath of nerve roots and they get intrinsic weakness in both their feet and their hands. This is what his feet looked like, and this is what his hands looked like. He had intrinsic weakness, but he was extremely functional. He was like he was a truck driver, but very functional. And Charcot-Marie tooth is also called progressive neuropathic perineal muscular atrophy, hereditary perineal dysfunction neuropathy, hereditary perineal neuropathy, hereditary motor sensory neuropathy. I think that's the most latest one that everybody uses. So here's his MRI, which shows, well, what does it show? Eric, what does it show?
4-5's got a due to desiccation, L4-5 with disc herniation posteriorly.
So L4-5, you have a posterior disc herniation. The disc is desiccated, like Dave's been worried about.
Some hypertrophy of the ligament flavor posteriorly.
See that? That's a little bit hypertrophic. How about
5-1's got degenerative disc, almost complete loss of disc height with pathology posteriorly.
right? Disc height's gone, and reticulocesis. See, this point here is behind this point here. So that disc, not only is it degenerated, but it's shifting somewhat too. And that just goes, this is a thecal sac of the nerve roots. You can see the compression there. So what do you see at L5S1 on the axial cuts, Eric?
Central right disc bulge, it causes an extent into the frame, but it doesn't look too narrow on the right side.
So this is L5S1, this is the right, this is the left, this is the S1 nerve roots here. There's a little circle, and you can see it's compressed on the right. Yeah, hitting the disc right there. And how about 4-5?
At the level of the pedicle, assuming 5, at a right central right side disc herniation.
So it's pretty large disc herniation. This is what the thecal sac should look like. It should be a nice round circle with nothing hitting. You can see this one's hitting it. So this man's 60 years old, right sciatica. He had a fall in July, and he's had these symptoms for like 3 or 4 months. So would anybody treat this person differently with Charcot-Marie tooth disease? Or does anybody have any thoughts? Therapy? So this was an unusual case, and he had a large free fragment right here. This kind of shows you where the free fragment was. These are my post-op drawings, and it was up against the pedicle. And I did a hemilaminectomy and opened up both nerve roots. He was an interesting case. He had horrible neuropathy post-op, and I gave him steroids, and it went away. But I'm not sure if that had something to do with the fact that he has Charcot-Marie tooth disease and his nerves are abnormal. And I told him that's an issue with him. But eventually he had a good result. Like after 3 or 4 months, his pain calmed down. Okay, so any other questions? You guys want to do the mystery case, or I'll show the mystery case next month. I wanted Adam to tell me what it was. Okay, that's it. Thank you everybody for coming. Any questions at all?
So, put a plug in for Charcot-Marie tooth then, CMT. It's something that I treat for a long time because the primary manifestations are foot disorders. And it used to be sort of like you have it or you don't have it, but some people have more progressive disease than others. So now they've figured out that, where you have a gene where there's a defect, there's something like 60 alleles on it. And you can do genetic testing for this just with 2 tubes of blood. And what it will tell you is how many of the alleles are involved. And that's really the thing where people just have like, I have, a high arch in my foot versus someone who has pretty significant involvement like this. And the second thing it has to do with is the genetics of it. If someone has it, what's the chance that your
Kids have it.
your offspring are going to have it? So
It's dominant, I think.
yeah, but it is. But what happens is the more involvement you have, some people have very subtle involvement. They don't even know if they have it. Like, yeah, my father had high arches or something
Right.
like that. So, it used to be that you could test it, you could diagnose it by EMG, but the genetic analysis now is much more accurate than EMG studies.
How much does that cost? What do you
Under $500. There's a company out of
under $500?
Cambridge, Mass. They send you the whole kit.
Oh, really?
You draw some blood, you send it, you FedEx it right back.
Does insurance pay for it?
I don't think so.
So I guess if someone's got a lot of money and they're worried about their kids, who'd pay for it probably. That's a lot of money.
So is my car payment. So is most of these people
Your
want
car's paid off, isn't it?
People want insurance to pay for everything, and the correlation is it's kind of like having car insurance pay for your oil change.
Got that old Mercedes. That thing's got to be paid off by now. Okay, so any other questions? Yeah, I'm sorry.
With the 19-year-old, would you have gone for aggressive PT following it because she's got so many years ahead of her to teach her how to properly use the core so she doesn't have recurrent back pain?
I give everyone the option of physical therapy, but I don't demand it. So I talk about what physical therapy is, and I give them the referral, and I let them choose. So that's how I practice. So I just tell them what it is and how it can benefit you, strengthen, increase range of motion, things like that, teach you things. And if they choose to do it, I give it to them and they go. So that's how I handle it.
What percentage technically tend to go?
I'd probably say probably like a third of people want to do it. I used to send everybody, and I got a lot of complaints. They say it's really expensive, I don't have the time, and after that, I just leave it up to the patient, unless I see someone who obviously I think needs therapy. So any other questions, anybody?
With that 19-year-old Spiro, any significant histories